Welcome back to Beyond the Thyroid. I am Dr. Dana Gibbs. Today we're going to explore the fascinating intersection of fertility with hormone health. My guest today is Dr. Oluyemisi Famuyiwa. She is a board certified reproductive endocrinologist, obstetrician gynecologist, and founder of Montgomery Fertility in Rockville, Maryland. She was originally born in Nigeria but came to the U.S. for medical school at Emory University. She completed her OB-GYN residency at Georgetown and then pursued a prestigious fellowship in reproductive endocrinology at the NIH, where she also spent 3 years doing cutting-edge hormone research after she finished fellowship. Now she's in private practice and helps patients of all backgrounds navigate infertility. She's also the founder of an innovative egg bank that focuses on ethnically diverse donors. It's something that is really sorely needed in the fertility space. So in this episode, we're going to talk about how thyroid disorders can impact fertility, what egg donation really involves, and why early education and planning can make all the difference on people's journey to have the family that they want. So let's dive in. You're listening to the Beyond the Thyroid podcast. I'm your host, Dr. Dana Gibbs. I'm an ENT surgeon and hormone specialist. For years, I struggled with my own unrecognized thyroid problems before and even after I was regularly performing thyroid surgeries. Then, one day, I learned something that turned my health around and opened my eyes to the limits of mainstream medicine in treating more subtle thyroid abnormalities. I spent the next 20 years fine-tuning my hormone expertise in disorders like Hashimoto's disease, perimenopause, and stress-related illness. Come join me as I share this new approach to hormones that empowers you to take control of your own thyroid and hormone imbalances. Let's dive in. All right. Hi, everybody. Welcome to Beyond the Thyroid. Today, I have a special guest for you. It's Dr. Yemi Famuyiwa. She is a reproductive endocrinologist, fertility specialist in Maryland and owner of a fertility center there. And she has come to talk to us about fertility and what fertility specialists do. And she's mostly here to educate me because I know very little about her specialty. And I'm so excited to have you here.
Thank you so much.
Welcome, Dr. Yemi.
Thank you for having me.
You're so welcome. So Dr. Yemi got her medical degree from Emory University in Georgia and then went on to residency in obstetrics and gynecology at Georgetown. And I'm going to let her take it from there because I want to know what makes somebody decide that they want to go into reproductive endocrinology from
fascinating.
obstetrics and gynecology.
Right. So I'll wind it back a little bit. I went into OB-GYN because I enjoyed it. It was fun. Bringing life into the world is just pure fun. But in my residence, I originally thought I was going to be a GYN oncologist, but I didn't like the part where a lot of people would pass away from complicated surgery, cancer, and it was a little hard for me. It takes us. I respect GYN oncologists.
Boy, it just takes a special kind of person to help people who are in such bad straits.
Yes. So fertility for me is more the raw science behind it was more fascinating. You get a lot of basic science with it. So I was actually really more interested in the science of the hypothalamus, the pituitary, the ovary, what's going on in the glands, why are some people be able to get pregnant, not able, and what was the science behind it? And when I was looking around, I applied to the fellowship at NIH and I got in and it was very fun. It was many, many moons ago. Back then, the fellowship is a little different now. It was more hardcore science focused. So we did do a clinical part. We, went to it was then called the National Naval Medical Center. But then we spent most of the time at the NIH doing bench research. And that can be intoxicating, right? You're on the cutting edge. I was very blessed to work in a lab where our lab chief, who's since passed away, was highly published, well published, was able to get a lot of grants and research grants going on. So at any one time in the lab, there was always like 6 or 7 or different types of research going on. She was actually, believe it or not, a medical endocrinologist, but she
Hmm.
wanted her lab to focus something on the reproductive part. So I, and along with another fellow, came in for that part while they still looked at other endocrine systems.
Hmm.
So we did that and did a lot of hardcore bench research. And it was a lot of fun because then we got to go present those at national conferences,
Oh,
which is
yeah.
exciting, going to Endocrine Society,
Hmm.
presenting articles, presenting papers, flying all over the country once we get our research.
Yeah.
And my lab chief, Dr. Bundy, was so skilled. This is someone who could go home on a Friday and flesh out a paper for you by Monday, with research. Extremely intelligent, brilliant woman, and
Hmm.
was a mentor for me. So I really admired her. And I found out after I finished my fellowship, but I stayed an extra 3 years because that was what we were doing. We were having fun. We were doing research.
Hmm.
And then I realized I actually also liked the hands-on patient part, maybe a little bit more than the bench research,
Hmm.
right? So it was a toss-up between the two. And so the patient interaction won, and I went into
Okay.
private practice.
And not just private practice. You are an entrepreneur. You built your
Yes,
own fertility center
yes,
there in Montgomery County.
yes,
And you even built an egg bank, which I do
correct.
really, really
Yes.
love that idea. And I want you to tell the
Hmm.
audience
Hmm.
what an
Yeah,
egg bank is and why
right,
you
right.
felt like the
Yeah,
big national egg banks were not
exactly.
sufficient
Right,
for
right, right.
your patient population.
Yeah. So the center, Montgomery Fertility Center, came first. And we also had, we had a few egg donors here, there, the other. But then I guess closer to COVID or right around COVID, a lot of our patients could not get the eggs they needed or get the donors they needed. Or if they called, they would be told, well, you only have half a batch. So, you can mix 1 egg here and 2 eggs there. And they want all their kids to come from the same genetic material, right?
Hmm. Hmm.
So it was getting much harder to try to pair them at that time. So
Yeah.
we explored trying to start our own because we're also at a very good intersection of a lot of cultural diversity where our office is. And
Hmm.
so we did our research, we learned about it, went to the egg donor conference, and then launched our egg bank and haven't looked back since. So our egg bank features a lot of different ethnicities, cultural backgrounds, because, some of our patients are very specific. I want an egg donor from Eritrea. I don't want an egg donor from Ethiopia. But if you look at them, they're, to me, they look almost the same. Don't say that, they'll hate you for it. So, or they'll say, well, I want an egg donor who comes from the western part of Nigeria, and I don't want an egg donor who's from the northern part, or I want someone from South Sudan. People are very specific. I want
Hmm.
someone who is from, Gujarat in India or not, so we are at an intersection of a lot of cultural diversities where we could get access to those donors. And also the other thing too is we also have a very strong emotion. How would I say? The way we treat our donors, we feel very particular that the donors are doing an altruistic service
Hmm.
and they ought to be treated well. And we don't overstimulate our donors. We're very careful trying to restrict, okay, you do this many egg retrievals and then you're done. And we also handhold our donors. So when you get a retrieval, we make arrangements to have someone stay with you, a visiting nurse, whatever, to make sure
Hmm.
you're okay for the night, right? So you're not
Yeah.
just donating your eggs and, wham bam, get
And
out the
wham
door.
bam, get out of here. Yeah.
Yeah.
So
So
talk a little bit more about that because that's something that
mhm,
I don't know a whole lot about, and I know my
mhm,
audience probably doesn't. So how do you become an egg
mhm,
donor? How do you get recruited to be an egg
mhm.
donor?
So
And then
yeah,
what's that process like once
yeah,
once you decide, hey, you know what, I want to donate eggs so that somebody else
yeah.
can have a baby?
Yeah. So you really have to think carefully about it. It has to come from a place of altruism, I think. Most of our egg donors started with having sisters or cousins who wanted to donate for their family members. You have to see it
Mm-hmm.
from that point of view first.
Mm-hmm.
And then you have to, I always tell my donors, look, in this day and age, 23andMe is out of service right now, but there's so much genetic material out there that someone could really triangulate and pinpoint and say, wait, 18 years from now, someone knocks on your door and say, wait, you donated the eggs that made me. So how are you going to deal with that
Wow.
emotionally, right? So you have to be okay with that. There are certain people now pushing for open donation. I have some donors who they and the parents, by mutual agreement, decided they want to stay in each other's lives, right?
Mm.
And I had a patient who came from a Greek background, and it was very hard to find a Greek donor for her. And she did find one, and she and the donor bonded, became friends, and they said, "Well, we're not going to bother you, to raise our child or anything like that, but we wanted to know you and know who you are." And she wanted the same. Said, if our child wants to contact you in 10, 18 years from now, how would you feel? And by mutual agreement, they agreed on that, right? So
Wow.
that's very important. And then when people sign up to be donors, we do genetic screening on them. We do psychological evaluation on them as well, because they have to understand, for instance, if you have a donor who may have a history of bipolar disorder in her family, that can be transmitted to an offspring, right?
Mm.
So you want to
Okay.
carefully screen for those minor things. And, I know some people go overseas and, oh, let me just get eggs, it's cheaper overseas. You don't know that those donors have had that psychological evaluation or the psychological screen.
Screening,
So
sure, absolutely.
if you have a child who has a serious psychological or psychiatric issue in the future, that was never screened for, right?
Mm.
And most importantly, that I feel strongly about, it has to come from the women have, it has to be their free will. So when you get eggs overseas, you don't know if those women were trafficked, you don't know if they were coerced, right?
Mm.
And we only accept probably 2 to 3% of people that actually apply to our center. We don't take everyone.
Mhm.
We really feel strongly about those criteria.
Yeah.
And so we turn down a lot of people,
Mhm.
and, if you're doing it purely for the money, maybe this is not the right bank for you.
Got it. Okay.
Yeah.
Well, so from the other side, from the flip side,
Hmm.
so when a person comes to a
Right.
fertility center, when they
Hmm.
come to you as a patient,
Right.
are they automatically going to be using donor eggs? What's the process?
I
Because
see.
my,
Yes,
yeah,
absolutely.
I need more
Yeah.
education
So
about
it's
this.
it's not automatic at all.
Okay.
Most people want to use their own eggs, but
Okay.
you may have some people who, for surgical reasons, have no ovaries, or
Hmm.
they may also have had immune destruction of their ovaries. We talked about that earlier. People have premature
Immune
ovarian
disease.
insufficiency that's not
Hmm.
reversible, or people have had chemotherapy in the past, or they just don't have ovaries, right? Different gender. And then there are some patients who they come in very late in their 40s thinking, wow, I just found Mr. Right. Now I want to have children. And then you're testing them, you go, you don't have any eggs left, or whatever is left is just not
Hmm.
functioning.
Yes.
And that takes a lot for them to understand. Very few people can digest that. So you
Hmm.
don't just go straight to donor. There has to be a process. And we try to use your own. There's a lot of science coming out now, still experimental and mostly
Hmm.
outside the country, where they're saying, well, can we rejuvenate your ovary using stem cells, for instance? Or can we
Ah.
heal the ovary using platelet-rich plasma? It doesn't always work, right?
Hmm.
So it's for someone who maybe they're like, okay, I know my last bet is going to donor egg. I just want to give it one last shot so
Hmm.
that I don't have that regret when I'm 60 or 70 that I didn't even give it my all.
Didn't
So
even try. Sure. Yeah.
yeah, so there is a process. You don't just go straight to donors. You try
Hmm.
first and we evaluate you and see
Yeah.
what is the medical need, the necessity for that.
Yeah. Very interesting. So I had a baby when I was 44.
Lucky you.
And the reason I was able to have a baby at 44 was because I had gone years and years I think, and I'm guessing because I did not go to a fertility specialist, I was anovulatory for years. I didn't have periods because my thyroid was so messed up
Oh my
and I
gosh.
did not have an abnormal TSH. Nobody ever cottoned on to it. And then when I finally started on thyroid medicine, it was like, oh, my periods are regular. What the heck?
Yes.
And I was in a fairly new relationship. And I was like, hey, I'm going to stop taking birth control pills. Let's see what happens.
Uh,
And got pregnant at age 44 and had no idea how unusual
That is.
that is,
And how lucky you
and
are.
and how lucky I am that my baby was okay.
Yeah.
Because the older you are, the more likely there
Mhm.
are defects, and so
Mhm.
it was a very,
Yes.
very unusual
Yes.
thing that happened. But I have many patients that doesn't happen for, and
Yes.
they went for a long time unable to conceive or unable to carry because of thyroid problems, and then all of a sudden it's like, oh wow, I think things are better and I would like to try again to have a baby. And it's
Right.
like, okay, at this point, and I know there's an age cutoff at which you are advanced maternal age and it's high risk, and you probably should consider doing in vitro so that you can have a genetic look at the eggs before they go
Correct.
on. And so, yeah,
Yes.
I'm so curious about what that process would be for those
So
people.
yeah, because we do know that as you get older, your eggs get older. So when you try to, and it's not so much the eggs get older, you have oxidative stress and damage to, your eggs are frozen in a state of division, the first, phase of meiosis at birth. And they stay frozen till you start menstruating, where they activate and then complete division when the sperm hits the egg surface, right, to
Mm-hmm.
fertilize. So what happens is the DNA of the egg is lined up ready to match with the sperm and is frozen and held by what's called telomeres, right,
Mm-hmm.
to the end, the poles of the nucleus. Those
Mm-hmm.
telomeres, think of it like the Golden Gate Bridge, right? The cable spans
The cables that
with,
are
yeah,
hanging,
yeah,
yeah.
yeah, yeah. So those cables, they start to snap, right? And the
Mm.
one of the ways I tell my patients, imagine you're playing musical chairs, and somebody cuts off the music and you have sitting down, but you don't quite sit down. And then you have to stay like that for what, 13 years or more, or 40? Well, sooner or
Mm-hmm.
later, your leg muscles and your bones are going to start snapping and
You're
things
gonna
are going
give
to
out.
start. Yes. And that's what happens with those telomeres. So you can no longer present the DNA to match the DNA of the sperm correctly. So you can
Mm.
have, when the fertilization occur and you start to divide, some cells will divide with not enough DNA going to the daughter cells, or too
Mm.
much DNA parting the other way. I call it a genetic accident. The technical term is aneuploidy, right?
Right.
And very few aneuploids can survive, right? The only one that can survive is really like Down syndrome, where you
Mm-hmm.
have three of chromosome 21. That's Down
Mm-hmm.
syndrome,
Mm-hmm.
right? But even then, 80% of the Down's babies will miscarry.
Mm-hmm.
20% make it. But then there are other trisomies out there, like trisomy 7, that can never be a live birth, or
Mm-hmm.
trisomy 13. You'll never get a live birth out of that. Trisomy 7 tends to miscarry early, like 7 or 8 weeks.
Mm-hmm.
Trisomy 13 tends to miscarry more like 12, 13 weeks. And then you
Mm-hmm.
have any number of things that can happen. So
Mm-hmm. Oh yeah.
depending on the severity, you might deliver carry to term, but then what you have is a child with severe defects, right?
Mm-hmm.
So,
Yeah.
so that the aneuploidy,
Mm-hmm.
right? I call it genetic accident. It's real. It's real.
Yeah. And it
Yeah.
gets the older you get,
The
the
older
more
when you,
likely it is to happen. The
yes,
percentage
when you
chance
get
goes
over
up and
40,
up and up.
yeah.
Yeah.
Mm-hmm.
Yeah, it really is kind of frightening. And, especially now in the environment that we have where ending a pregnancy is really not even possible anymore.
Yes, for
By
some
the
states.
time the fetus is old enough for us to know, okay, this fetus has a genetic abnormality,
Absolutely, yes.
it's too late. They won't,
Right.
they won't,
And
they
and
won't let you
also,
go. And
yeah.
so if you can know, okay, this
Mm-hmm.
egg
Mm-hmm.
these eggs have been examined before they're even used and they're
Mm-hmm.
safe, then it seems like for an older person that makes a lot of sense.
Yeah, and also if you know that you're going to get a miscarriage with the trisomy 7, I
Right.
don't know, most people say, yeah, yeah, it doesn't matter. Well, it does
No,
matter.
no.
Going through a
Miscarriage is a
miscarriage,
pretty horrible, traumatic
it's
thing and dangerous sometimes.
you get PTSD from it. You remember that lost birthday. Keep saying, well, what if my child had lived, and what would my child be doing now? So
Yes,
if you can save and spare a patient from that emotional trauma and that PTSD, then it's a good thing to know
absolutely.
if
Absolutely.
you have an embryo that's genetically capable or not.
Hmm.
The only time you might not do that is if you don't have any embryos to test, and you just say, okay, just put what you have back in, right? And
Right.
then but you have to understand the risks, right?
Hmm.
And then there are patients who've had what is called a mosaic, where you have a mixture of good and bad cells, and
Hmm.
sometimes the good cells will override the bad cells and sort of correct the embryo, and the embryo comes out normal.
Hmm.
And I've had patients like that where all we had was a mosaic embryo, but it was a low mosaic.
Hmm.
And that was all we had. And she
Yeah.
didn't have any
And they
more.
wanted to go ahead.
Right.
So,
And we
yeah,
put it in, and the baby delivered, and it's actually a normal baby right now. So that can happen
fantastic.
as well. Yes, yes.
Yeah,
Yeah.
fantastic. But in those situations, I can see how you might end up then wanting to go for a donor egg.
Exactly. For
Yeah.
people we've had some patients where, if they have what is called a translocation. So if
Hmm.
the parent has all the genes, but there's a little bit of a mix up. So maybe half of chromosome 11 is stuck on chromosome 6, and chromosome 6 half is stuck on. So technically they have all the components, they have their full DNA, so they
Hmm.
don't have any symptoms. But when it comes to fertilizing and creating embryos, that
Hmm.
translocation now becomes a big problem.
Big problem.
So
Yeah.
they get embryos that are just not genetically normal at
Yeah.
all.
Yeah.
So,
They don't have
and
enough DNA in some and they have
yeah,
twice as much in some. And it's just like,
exactly.
yeah,
So those
they can't
patients may
necessarily survive.
consider absolutely,
Yeah.
absolutely.
Interesting. Very interesting. All right. Well, I guess, is there anything else in particular about the process of coming through to infertility treatments that my patients would know that I don't even know enough to ask you?
So I think early education it's all about early education. So now I partner with a lot of my primary care colleagues, my GYN colleagues, and I say, look, someone's been trying for 6 months, send them over. Someone has some genetic problems in the past, send them over. They have medical problems in the past, thyroid problems, endometriosis, fibroids. Don't
Hmm.
wait, send them over.
Hmm.
And I've also worked with some of my colleagues where I've trained them with the preliminary workup that I want them to get started. So when I'm
Yeah.
seeing them, half the workup is done, it cuts down a lot of time.
Yep.
The worst thing you can do is delay your time to seeking treatment, and then come to find out you have something that could have been corrected 2 years before,
Yeah.
right? But they
Hmm.
never sought help on time. So
Right.
if you are, or even, for young women nowadays, professionals, doctors, lawyers, engineers, if you think you want a family in the future, come see a fertility specialist, get your egg frozen,
Yeah.
pre-plan, talk about it. And
Yeah.
and that's, what I'm doing now. I'm
I
writing a
think
book on that.
for a lot
Yeah.
of physicians, and
Mhm.
I think if you would have asked me when I was 20, was I going to have kids? I would have said, no, forget that. Not going to do it. And then here I am when I'm in my 40s going, well, I met the right guy and here we go. And and I should
Yes,
have frozen the eggs 20 years ago. Should have
exactly.
done it. But anyway,
Yes.
all
So we
right.
want
Well,
to take that
super.
regret. Yes.
Super. So how can people find you? I know you have your own podcast. So
Yes,
the
my
name of it
podcast,
is,
yes. The Fertile Talks with Dr. Famuyiwa. It's
okay.
Fertile Talks on
Okay.
on Spotify, Apple Podcast, Amazon, anywhere you get your podcast, Fertile Talks. You can go to our website at Montgomery Fertility Center, one word.com, and we'll be
Mhm.
happy to, you can hit the contact us button there,
Right.
and we'll reach out to you.
Okay. So anybody who lives in the Washington, D.C. area and
Yes.
wants an absolutely fabulous fertility specialist, check them out because
Thank you
that's
so
really
much.
cool. And the egg bank, I'm so excited about your egg bank. I just think
Thank
that's
you.
the coolest thing ever. All
Thank
right.
you.
Thank you guys for listening to Beyond the Thyroid. I know this was a little bit off of our usual topic for today, but thank you for sticking with me and hanging in there. And don't forget, I have the Thyroid Clarity Checkup course coming up. If you are interested in finding out if you have thyroid abnormalities that have not responded to the usual labs or shown up on the usual labs, come and find me at danagibbsmd.com/checkup and get on the waiting list for that. It's going to be super helpful. So I will talk to you guys all next time. Thank you for listening to this episode of Beyond the Thyroid. If you found this information valuable, it would mean so much to me if you'll take a few seconds and give the podcast a 5-star review. It helps other people who need this information find the show, and it's really easy. Just search and click on the name of the show, Beyond the Thyroid, and scroll to the bottom to ratings and reviews. I truly do read and appreciate every one. Remember, when it comes to hormones, there will always be more to discover. So follow the show so you get the next episode as soon as it's released. And if you or someone you care about needs a caring doctor to help figure out how to heal hormone problems that other doctors have dismissed, check out my website at www.danagibbsmd.com. And if you're not a physician, please keep in mind, while I'm a doctor, I'm not your doctor. The content of this podcast is my opinion, and it's for educational and entertainment purposes only. This is not meant to be individual medical advice, and you should consult your own physician for any medical issues or diagnoses that you may have. I look forward to continuing this journey with you beyond the thyroid.